my honor and pleasure today to talk to Dr. Mario Milch, who is one of my mentors and maybe one of the most important influencers of my medical career and how I've learned to interact with patients. And he's gonna give us a talk today. And it was a talk that I heard maybe about, I don't know, 10 or 15 years ago that really has stayed with me. It is really a culmination of what he's learned as a physician for 50 years. He's been in hospice care for over half of that time. And as an internal medicine trained physician, he's really learned how to take care of everything. And, we'll kind of talk about how he weaved into hospice and palliative care um, later into his career. So, Dr. Milch, thank you for being here.
Thank you for having me.
And I always have to work really hard to not call you Dr. Milch because you've told me to call you Mario, but it's so hard because you are this person that I regard like here. And I just have learned so much from you. And I just wanted to have this interview recorded because I wanted to have it for myself and I wanted to share it with other physician colleagues, patients, because I think you have a lot to share that's really beautiful and important as part of that patient-physician interaction. And I think today we're going to be giving people an insight into how you as a physician navigate end-of-life care, how you show up for people in the most difficult of situations. So can you tell us a little bit about your background and your training?
I'm actually a native of Argentina, and I came here at a young age, about 14, and lived in Detroit, suburbs of Detroit, for about 2 years until we decided then there must be a better place to live. So we moved to California. I went to UCLA undergraduate, and then I went across town to USC Med School. That was the 60s and the height of the Vietnam War. And I did not want to go to Vietnam. And I lucked out and joined the public health service, which was an alternative to military service. And so that was wonderful. I was stationed at the Presidio in San Francisco. And we took care of merchant seamen, Coast Guard, and a few military. Ultimately, finished internal medicine residency in Kaiser, Oakland. I did some emergency room work, and eventually I moved to Los Angeles and joined as an internist.
Mhm.
And I was a general internist. And I started doing some what was considered geriatrics in those days, which was nursing home visits. Medical director of Kaiser Los Angeles asked me if I wanted to do hospice. And at that time, it was early 80s, hospice became a Medicare benefit. And so Kaiser, which had offered limited hospice services, decided to just open it to everybody that was eligible. I'm not sure why he thought of me, but I said, okay, let me research it a little bit. And I did because I didn't know much about hospice at that point. And I said, this is something that I think would fit me, hospice. This would provide some of the reasons I went into medicine. And so at that time, there were no fellowships. A lot of it was you learned by doing and some reading. I did go to Great Britain um, to study a little bit because that's where the modern medicine, modern hospice program started. So I think we can show you some of the slides from that, unless you have other questions.
I do have those slides and we'll share that in a moment here. And I can think of like 100 reasons why you were asked to do this new venture, knowing who you are and just the type of human that you are. So, and you know how I came to meet you was that I wanted to get boarded in hospice, and at that time you had to have just sort of in the field experience, and I had called so many different places, and nobody wanted to take me, but somehow someone met me and said, "You got to call Dr. Milch." And I did. And you said, "Come on over." So we would get into your car in Los Angeles and we would drive from home to home doing hospice visits. And it was just the most incredible thing to see you in action because hospice is hard work. It's, you know, having difficult conversations, providing people with information in a way that's gentle but truthful and holding space. And as I came in contact with the nurses and the home health aides and the chaplains and all the other wonderful therapists that were on the team, I couldn't help but just think like these people are like otherworldly. Like this is like a calling. This is not like just a job that people do. And it's such a beautiful practice. And I wanted to share your story and your wisdom today because hospice and end of life care, palliative care is so underutilized. And there's so many benefits of utilizing it when someone is faced with a chronic disease and you know, a life-limiting illness. There's these resources there that we're just not using because it feels scary. So hopefully our conversation today will teach people a little bit about what hospice care is, and then we want to learn from your wisdom. So
Right, right.
yeah,
And,
anything else? Yeah.
and I want to emphasize that it is a team effort. That hospice is not just the physician, it's the nurse, it's the chaplain, it's the social worker, it's the aide. We have music therapists, and we can talk about some of the realities, but ideally, it is truly a team effort, you know?
I love this picture that I always have in my head it's from hospice care, but I try to apply that to my current practice. It's like I always tell my patients, you are the center of the team, you and your decision makers, your family.
Right,
And then all of us are outside the circle, the physician, the nurse, the therapist, the home health aide, whoever it is that's involved in care. And we are consultants to you. We're there to support you and guide you, but you're the ultimate decision maker. And you um, are the most important aspect of the team, right? You're at the center.
right, right,
And
right. And the great thing about hospice is it also includes the family, the significant others, you
right.
know? So they're also part of
Yeah.
the team. And I also want to put a plug in for palliative care. You know, palliative care came later,
Mhm.
and it has the advantage of the fact that with hospice, it's a Medicare benefit. You have to have a prognosis of 6 months or less and give up any curative attempts. And the great thing about palliative care is that it can provide some of the same um, uh, services and benefits, but um, it doesn't ask and tell the patient, well, you probably have only 6 months. So it can provide services for people who, yes, are ill, seriously ill. The problem sometimes with hospice is people interpret it as giving up, which it isn't, you know.
Right. I think it can enrich actually um, one's life and quality of life to have that team support around them. And I think that's missed. A lot of, like you said, a lot of people think of it as giving up or not doing enough. And I've seen just really beautiful things come out of this framework of hospice care where people are supported in a very different way. And, you know, we're focused on symptom management, making people comfortable, comfort care, rather than running to the hospital every week for whatever
Right.
emergencies coming up.
Right.
Because with hospice care, the nurses and the home health aides, the social workers, they're so well trained and able to do so much actually just in the home setting. So it's not like, yeah, you're getting nothing, you're in just going home. You're actually really well supported. All right, shall I jump into our slides? Okay, well, here's the talk I heard over a decade ago, and I've been thinking about it ever since. So it just feels like my honor and privilege to hear it again with you live. So I'll let you take it away.
When I went to Europe to study some hospice, we went through Rome and um, found this. I don't know if you can read it. It basically says Hospitium Devorum to the Virginis. And the word hospice is really old. It used to denote um, places where religious pilgrims used to go for shelter, um, and this is one um, very old. Hospices eventually became more for places for people who had incurable diseases like TB or leprosy. So the concept of, or the word hospice is really old. So this lady, Dr. Cecily Saunders, is really the mother of modern hospice. I think she was a social worker and became interested in so that a lot of terminally ill patients, the doctors lost interest if they couldn't cure them, you know, and they were not particularly good at symptom control, like pain control, and so she felt like a lot of these patients were abandoned. So she became a nurse and got more involved in terminal care and was told that if you're not a doctor, nobody's going to listen to you. So she went to medical school. So she was a team in one person. And I had the privilege of meeting her actually in Los Angeles, but not in Great Britain. Anyway, we were traveling in Great Britain with my older daughter, who is now 41. Um, Here she is at about 11 months old uh, in Great Britain, obviously. What Cecily Saunders eventually did is start uh, St. Christopher's. And this is the statue on top of the main entrance. This is become sort of the um, place of pilgrimage for people who are for not just physicians but other professionals who are interested in doing hospice and palliative care. Um, it's rather big and it sort of doubles up as a nursing home, but you got people from all over the world that come and get instruction. And it's interesting. When I was visiting Argentina, um, I got in contact with uh, other professionals and who were doing hospice, and they had come to St. Christopher's. For several weeks, we went to different hospices, not just St. Christopher's, but other hospices. This is in downtown Swansea in Wales. Obviously, this castle needs a little repair, but it's right in downtown Swansea. Uh, Go ahead. And I got to do some home visits in Swansea, and this was the nurse who was charming and lovely, um, except she drove on the wrong side of the road. But people were so wonderful when they learned that I was coming from the United States. They were so welcoming and offered tea and scones um, And this area is rather modest. A lot of coal miners. And, it's not really a very prosperous area, but really welcoming. So back in the United States, I did a little more travel. Uh, the Connecticut Hospice actually has the honor of being probably the first um, professional hospice. Before that, hospice came to the United States purely as a volunteer activity. Nurses, physicians were doing it as a volunteer activity. And Connecticut Hospice opened up a place. This is the front door of the Connecticut Hospice. And I think it's so representative of the tree of life, you know, and the fact that there's birth, there's also death. And in between, hopefully, we have a vigorous life, you know. But death does not have to be horrible. It can be meaningful. It can be avoiding, we try certainly to avoid suffering.
And, to your point, I think some of the most profound experiences I've had as a physician have been with patients at the end of life, and really just seeing how they navigate that with the right support in place. And I don't know how most people will take this, but that whole end of life experience and death can actually be really beautiful and a transformative experience for the patient and their loved ones that are surrounded by them. In fact, my father-in-law passed away several years ago from Alzheimer's, and it was just a really beautiful experience. On his last morning, all of his kids and grandkids were surrounding his bed, and his daughter went outside and took a picture of all of us through the window around his bed. And it's just something that's really stuck with me. It was beautiful. It really was. It was a way that we actually were able to honor him, making sure that he wasn't suffering and had a
Right,
nice transition. Yeah.
right, right. And the opportunity to say goodbye. And the wonderful thing about the Connecticut Hospice, again, is that it has a preschool on the grounds. And the kids actually came and visited the patient and mixed in. And it was a breath of fresh air for them, for the patient certainly, but it was instructive for the kids. And there are a few other places that have preschools or schools, the grounds, more like nursing homes. Um, I think it's a wonderful idea. More likely, they have pets.
Mhm.
And
Mhm.
I heard that there was one particular hospice where they have a resident cat who could sort of sense when somebody was about to die, and they went and they they went and they cuddled with that person.
It's like a CAT scan.
Yes.
Yeah,
Uh,
well, and I'm thinking about your comment about the children coming through. Like, I think our tendency is to, certainly for me as someone Iranian, as a child growing up, it was always like trying to shield the kids from anything
right,
that had to
right,
do with death or dying. Um, and I've really tried to do the opposite with my kids. Like, I will take them to funerals, and they did get to spend time with their grandfather and massage his feet and try to feed him, and trying to normalize this other stage of life that we like to
right,
really keep quiet, right? And avoid at all costs, right?
right,
So
right.
yeah, how beautiful that that's something they had incorporated.
So this is the Kaiser Permanente Hospice in Norwalk. And what Kaiser tried to do here in Norwalk and actually in Oakland was to reproduce the British model of hospice. And the British model, which I saw, was that there's a small inpatient unit, and this was a former nursing home. This provided about 12 beds, inpatient beds, and it was lovely. It had a day room where families could come. They could even cook, and and actually after the death, they had like a viewing room where the family could come and gather around. Um, and they had cots so people, family could sleep over.
I also want to just point out the hospice is very flexible. It can be done in many different settings, like the home.
Right.
Most often it's done in the home, but it can be in a nursing home, boarding care, and hospital facility as an inpatient. So, it just really is there to meet the needs of the patient and um, basically trying to provide what the patient needs with always keeping that in mind.
Most people prefer to be at home, but not everybody. And some people just absolutely say, I do not want to die at home. I don't want to have, my wife or my husband have that memory. Arrangements can be made, usually in a nursing home. Um, Here was the home care team that saw most of the patients. And actually, this facility closed because it's economically very difficult to you have 12 beds. It's difficult to be, particularly in the Los Angeles area that is so widespread, to accommodate people from, you know, uh, all over. And also, you have to have 3 shifts. So that's, again, very expensive. So uh, this facility closed, but uh, while I was open, it was great. So this is the for those people who live in Los Angeles, they may recognize that this was the Kaiser Permanente Los Angeles Medical Center um, before the new one got built 20 years ago.
Is this right off
And
of Sunset Boulevard?
yes,
Yeah.
it is. It is. And this facility was built in the 50s. And so, they built a new one about 20 years ago. There was this building across the street, and actually, we did use this. It was mainly for same-day surgeries, but we used it actually to house patients um, that, for one reason or another, could not be at home or didn't want to be at home.
Oh, this is where we kind of get into your lessons learned as a physician. And I think this is going to be such a beautiful thing for people to hear around really kind of the physician's perspective of what it's like to work in this field. So thank you for sharing this with us.
Sure. So Dr. Cecily Saunders was the one that came up with the concept of total pain, that somebody who is dying might be in total pain. And by that, she meant that not only were there physical aspects of the pain, but also psychological, whether it's, in my experience, it's not so much depression as maybe sadness. Okay. And the social aspects of what will happen with my family, how will the family do without me, the economic factors, but also the spiritual. And this isn't necessarily religious, but the question of what makes life worthwhile and what made life worthwhile. And how do you um, come to terms with the fact that it is ending? Is there uh, not only the concept of life after death, but the question of um, what do I leave behind, and what have I accomplished or not? So this is why hospice, as a team effort, tries to address all these factors. Okay. Now, Elizabeth Kubler-Ross was a psychologist, and she came up with these 5 stages of dying, grief, um, that applies again for patients who are dying, but also those that are affected by grief. And what she described is that there's a stage of denial. No, I cannot be terminally ill, and some anger, like, why didn't they catch it earlier? Why can't they cure me? Followed by bargaining. Um, I will be a better person if I get better. Depression, that you're not getting any better, and finally acceptance. Well, most patients have not read Kubler-Ross, are not aware of these stages, and the reality is, very few actually go through from beginning to end. Um, some people are stuck on denial, and that's not so bad because denial can sometimes ease
Mhm.
the pain of reality. And so denial has a bad uh, sort of a bad connotation, but the fact is it can be something good. Some people are very angry, the and those are the most difficult patients to deal with because they're just angry that they're not getting better, that the medicine cannot offer more, and so it's very difficult um, to deal with them. Um, I don't know how many people actually reach acceptance because, and I've had quite a few that say, I've had a wonderful life, I've had a long life, I'm ready to die. Most people, are just they exist just like we do day to day, and but have an opportunity to maybe review their life. And this is what hospice can offer, is like a life review, sometimes videotaped. And it's also the opportunity to make amends, make uh, uh, reconnect with people that you haven't and you wanted to, um, that kind of thing.
And the chaplains on the team can be very helpful with this process. So can the social workers. There's a lot of support built in to do that life review and to reframe things and help people sort of move through these stages and hopefully get closer to acceptance.
Right, right. Okay, next one.
Mhm.
So I made this presentation um, when I had a long history and career in Kaiser, and then I went on to after I retired from Kaiser to work at the VA, and that was great because they actually do have an inpatient hospice that that I I was involved in and doing palliative care, and also this national hospice called Vitas. So, um, but when I actually retired, I said, it's time. I've done it a long time. I'm ready to let go and get on. You know, uh, And so I came up with some concepts that I thought were important in my career and my effectiveness. And the first thing that occurred to me is that we have to listen as professionals. We have to listen to the patients, families, and because of the pressures of modern medicine, that sometimes does not get done. You know. Next one.
What's beautiful about hospice is sometimes these visits take 2, 3 hours. So you stay as long as you need to, right? And
That's right.
just the act of listening gives so much comfort to the patient, to the family, and helps people feel that they're in good hands. Because for someone to slow down and listen to you really is an act of caring. And it's such a beautiful way to start that relationship with the patient. So, yes,
Yeah,
absolutely. More
yeah.
listening.
So Oliver Sacks, uh, sadly one of my idols, said there's only one cardinal rule: one must always listen to the patient. um, Next one. Uh, William Osler, who was definitely a pioneer, said, in taking histories, follow each line of thought, ask no leading questions, never suggest, give the patients the words in the complaint. Um, this is ideal. He probably had more time than the modern doctors do.
Yeah, sometimes people are seeing 3, 4 patients in an hour. I mean, there's no time for any of this. You can
Right,
only talk about one medical problem,
right.
right?
Uh, this is so basic and yet so important. I remember as an intern, as a resident, those of us trooping to the bedside with the attending physician and just towering over the patient. Um, uh, Oftentimes the bed was low, and so we were really towering. And this is not conducive to communication. So one of the things that I always did and that I taught was when you come to visit the patient, and particularly if you if more than one, you know, if you're there with a nurse or chaplain or resident, find chairs. Sometimes we spend a lot of time finding chairs to sit at the bedside, you know.
Yeah, that
Uh,
versus like, with your hand on the doorknob, like trying to leave and talk to the patient.
right,
I mean, it just really puts somebody at ease if you are just seated and at the same
right,
level. And, there's no hierarchies in hospice, right? The patient is just as important as anybody else on the team. So I love
yeah,
that idea.
yeah. I think it's wonderful to have shared decision making. And certainly I'm old enough that I remember the patriarchal age where um, if somebody had cancer, the physician might make the decision not to tell them or not tell the family. It's wonderful that we now share decision making, but I think sometimes, particularly newer professionals, sometimes abandon professional responsibility to make recommendations. So, for example, CPR, you can discuss CPR, whether you're going to do CPR or not, but you can recommend, it's my opinion that depending on with your condition, it probably would not be a good thing. Here's why. Okay. It's your decision, but you know, you have to make professional responsibility. And I'm finding that some more young professional says, well, but the patient wants this. Well, okay, but was there a discussion of
Mhm.
pros and cons? Again, it takes time.
It takes time and they're hard conversations to have. They're complex.
Right.
There's sometimes multiple family members and the patient, and they may be at
Exactly.
odds about what's right. Culturally, there are cultures that are like, you must do everything until the very end,
Right.
be in line with their religious views. And so, these are complex conversations and complex decisions, but
Right.
your
Right.
recommendations can help patients get to a reasonable decision that makes
Right.
sense, right?
Right. Right. I think as hospice and palliative physicians and professionals, we don't necessarily are the ones that deliver bad news, not like an oncologist or maybe, another professional. But sometimes you have to say, you're going downhill and I'm sorry, but I think that the end is near. Sometimes that's the conversation that you have with the family. And the point is that it has to be delivered compassionately. It has to be given with empathy. You can't just sort of deliver it by note, but almost by rote. Okay, your loved one is going downhill. I think we're nearing the end. Okay,
I
and
actually remember an instance with you. We visited a patient. We were there a very long time. Patient didn't have much awareness, but we walked out into the hallway to go down the elevator, and the family member followed us out and said, like, what, how much time do we have here? What's happening? And what you said was something just really, it was so comforting and just so simple and honest that, I was taking notes because I was like, this is how I want to have these conversations. But you said something to the effect of, we're gonna, hope for the best and prepare for the worst. And, it could be on the order of just a few hours to a few days. It's probably not weeks and months. And, we don't know exactly when someone will pass, but the way you framed it was so reasonable and logical, and there was so much compassion built into it, where it was like, now this family member kind of knows what they're dealing with and how do they need to prepare mentally and emotionally, and what things they need to get together. Are there people that need to visit? And I just always remember that. You probably don't remember it because you do this all the time, but it really stuck with me, of like how you can deliver really difficult news to someone in a way that doesn't have to be crushing. It could be informative. It can actually help them figure out what their next steps are. I just appreciated that so much.
thank you again. This is easier than in hospice, probably in palliative care, but it's very important to try to involve the family, significant others, um, particularly because uh, and there's some research into this that, for example, when patients are told about a cancer, they may not hear a lot of what is being told. And so, if you have somebody with them, they can hear more of what is being said. Um, but particularly in hospice, that we do consider, again, that the whole unit of care has to be involving family and significant others. And occasionally, people are alone. They really do not have family significant others. The problem is then how to supply, you know, help. Maybe they have to hire help. And sometimes they have to hire help anyway because the family's busy. They're working. They can't be there for care that involves a lot of personal care. You know, I think this is so important is that there has to be hope. And it doesn't mean hope for a cure, but it can be hope for a good death, quote unquote. It can be um, hope for maybe a long lost relative or friend that they reconnect. Um, it can be a journey, a trip, you know, something that they wanted to do for a long time. That said, okay, I want to go to Ireland. Okay, maybe that's possible. Here are the medicines that you need to take. Miracles are sometimes a little more difficult to deal with. Keep me alive because there's going to be a miracle. And again, the way to deal with this is not to say, come on, there are no miracles. That's not the way to do it. I like to involve chaplain sometimes to also have a discussion about this. What I have said at times is, look, uh, I hope there is a miracle and that you get cured. But in the meantime, I want to do everything possible so you're not suffering. So we're dealing with the pain. The point is that we're not we're not obstructing the possibility of a miracle. We're not in the way. We will not do anything that would would um, would block a miracle from happening. These are difficult conversations.
But people with hospice training are very well poised to navigate these conversations. And I think
Yeah,
it allows there for a lot of healing, to hear words like this and to be realistic. And your
right.
comment about alleviating suffering and making sure that you're comfortable, like that's possible. That's actually what hospice does such a good
Yeah,
job of, like, the medications that are in the home that either the caregivers or the family can use to treat really difficult symptoms like pain, nausea, agitation, constipation. Like hospice does a beautiful job of empowering the family or the caregivers to utilize these medications in the home setting and not needing to keep bouncing back to the emergency room, which in certain circumstances is not helpful. They just, there's a lot of poking and prodding and more studies that lead to more studies. And so there's a lot we can do to get people comfortable. And looking back at my own patients that I took care of in hospice, most of them had a very nice, peaceful transition. Most people are very comfortable with hospice. So I just hope people listen to this and consider this when it, comes up.
again, this is in a sense basic, but it's important to find out what that person wants, what is important to them. And by what I mean is that sometimes the individual feels like, I want to spare my family. Okay. I want to spare uh, their pain of seeing me die. And it opens up a conversation about the fact that, they love you. It's not a burden. I've had conversation with them. They want to take care of you. That's one scenario. The other scenario is sometimes somebody that says, look, I don't want anything. Um, I want to stay home. Whatever it takes, I want to stay home. Versus somebody that say, no, I want to stay home, but when it's clear that I'm dying. I want to be out of the house. And then it opens another discussion. Look, we cannot, just like we cannot predict when you're going to die, we can't say that we're going to have enough time to move you up, but we'll try.
Yeah.
Okay. That's one thing. Again, for example, people want to say, I want to stay clear headed as long as possible. And then again, that opens a different discussion about the fact that they fear that morphine, for example, or another opioid is going to really cloud their thinking. And so you have to, again, have a discussion about the fact that no, we can titrate the doses so it doesn't knock you out and it doesn't make you a zombie and it doesn't make you an addict, which is a lot of those fears, you know.
Yeah, there's so much misinformation out there, and just by
Yeah.
giving people the right information and making it, giving them permission to use these medications in the home can be so healing and so comforting. I mean, like you said, so many patients are afraid to use these medications, but I've just seen them be miracles, in patients that just really need them.
Now, this is interesting. Particularly, there are certain cultures where really the individual is not making the decision. It's a family, or it's the patriarch, or it's the matriarch that really makes the decision. And it's important to get a feeling for that and involve the family even more because the patient may say, yes, I'm going to take, I don't want to be in pain. I want to take the morphine. But the sister or the brother says, absolutely not. We want them alert. And so, again, the person to um, to discuss it with is that decision maker or making sure that it everybody's informed. That's what's recommended. You know,
This can get very sticky in hospice care.
yeah,
Come across different cultures where there's a set of beliefs, and what we might be recommending is in conflict with that. And then we have a hard time watching a patient have symptoms that are not controlled because the family, for example, doesn't want the opioid medications for the reasons
right.
described. And it's just a lot of building rapport so that they trust us. Hopefully, they like us and they value our expertise. And hopefully, they'll come around. But, this can be one of the most difficult things I've had to deal with as a physician, especially when I was very new. It was like navigating these conversations is really, it's an art. It really is.
Yeah, it is. It is.
Yeah.
And you have to be patient. And
Absolutely. Like I said, 2 3 hour long visits, which was like a big change for me because I started doing hospice visits with you after my anesthesia training, where we just spend 2 minutes talking to a patient, and then I went to 2 hours, and I actually loved it. So, all right, here's our next topic. This is a good one.
um, this is important. And this is the one of the values of doing home visits. And by the way, I I loved home visits. I I so enjoyed, just maybe not the traffic, but the just going to the house and just taking the time. And also people are not as defensive because you're in their territory.
Yeah.
Um, but you can see, if you come to a house that's neat and clean versus some where, everything is piled up and, and know that there's a problem with the support system, and particularly if the caregiver says, "Oh, he's there, okay," goes away. You have
That
to
happens
go
a lot.
find him,
Yeah.
and so you have a good idea, and this is leads to again working with the team to say, look, it's clear that the support system is really weak, and we have to really uh, keep keep watch and make sure that the patient is not neglected. You know,
So you bring up a good point, and maybe this is what patients don't recognize, is that once a week when I was working with you at Vitas, the team meets, the team covers a regional area, and it's all of the home health aides, chaplains, social workers, nurses, physicians, and they just go through each patient. They run the
Right,
list. And I used to remember that the home health aides, the people who will go in and help with bathing and dressing and personal care, oftentimes had the most important observations
right,
about what this patient is lacking, what needs to happen, what we need to watch out for. And so there's a whole team effort that's happening in the background. And I do remember when patients would pass, these people are not made of stone, the healthcare providers. There would be tears. We would spend time honoring that person's life. So it's really beautiful how this team functions and how much care is putting into delivering this
right.
really difficult care in the home setting, which hospice has just figured out how to do so well.
Yeah. And by the way, sometimes the aide was the most welcome person of the team because people love to have that personal bathing, cleaning, massaging, you know.
Yeah. A lot of people lose that connection of touch at the end of life.
Yeah,
Maybe it's a person who's lost their spouse and they don't have people that are very close to them. And so just having that home health aide present and do that hands-on care is so special and so
yeah.
important.
Connecting personally doesn't mean that you become too involved. After all, these are people who are going to die, and um, you have to keep some emotional distance. But when I say connect personally, is to try to know that person just more than as a patient. What did they do? What were their interests? Where did they live? What you know? So what what hobbies did they have? It's important to have that connection. Frankly, the people that I had the most trouble having some emotional distance were the people that were my age, and so of course that kept getting older. Uh,
And there was more of them.
and also that had kids of my age, you know. And of course, when you have kids as patients, again, that's a whole different ball of wax.
Right. And I
But
don't know
the
if people
point,
realize, but there is pediatric hospice as well.
yeah, yeah. So I again, it's important to have that connection of looking at them, touching them. And when I mean touch, and this is maybe more controversial these days, but I'm talking about just putting your hand on their shoulder as you're talking,
Mhm.
or putting your hand as they talk and they get emotional that they need some support that putting your hand on their knee it's not inappropriate touch. It's just an extension of empathy.
Yeah.
Okay. And it's okay to commiserate, to say, I'm really sorry that you're going through this, and I know it's difficult. And again, it's almost a human touch.
Yeah, absolutely. This goes a long way. This is really part of bedside manner, that maybe we don't even have now that we practice a lot of medicine through Zoom. But even through Zoom, you can kind of figure out how to do this. And sometimes I think the best doctors aren't maybe the smartest doctors or who have the most knowledge. It's the people that know how to comfort just by being present, showing empathy, and being genuine in their concern. I love this one.
So one of my favorite things was just having a light touch, having a little time to just sort of kibitz. I say kibitz is a great Spanish word for just doing some light talking. Actually, it's not Spanish, it's
I was gonna
Yiddish.
say. You've got both sides, so it all runs into each other.
And the benefit is sometimes you get fed that way.
So true. It's lovely to be involved in these families in this way. It's very special,
Yeah,
it's very
yeah,
meaningful to me to be included as an
yeah,
important person in that person's care. So I always
yeah.
do that too.
And humor is not out of the question. It doesn't have to be dark humor. One of the things that I loved that there's sometimes is, I saw somebody, elderly, and I would say, "And how are you today, young man?"
Hmm.
And that broke the ice. Or how are you today, young lady? You could see that, oh, this is not the Green Ripper, come to visit. We're not necessarily talking about jokes. We're just talking about just some lighthearted um, conversation and humor that sort of breaks the ice when appropriate. You have to be careful that it is appropriate. Again, I talked a little about denial being a defense mechanism, and um, and sometimes you have to say, okay, they're in denial, and that's fine. Trying to break the denial can be risky. Now, again, sometimes the denial is too much. I know I'm going to be cured. There has to be a cure. I'm going to find it. Okay, you can't generally go confront this head on because all you're going to do is just have conflict. One of the great things, actually, that I've read is that there are some people who are just so fearful of death that that really are um, at a standstill, and that psychedelics actually can help. I read there's one research experiment where just one dose, one treatment with psilocybin, which is the active ingredient of LSD, I believe, or it could be the mushrooms.
Yeah, it's the mushroom.
Psilocybin can really, in essence, take away that fear. And people say, "Oh, okay, I'm not. I don't fear death so much anymore. I can accept that. You know, that can be the end." Okay. Again, this is a controversial thing, but I think that there is room for using psychedelics in the end of life as well.
Yeah, I would love to see more of that. I've been, trying to learn about this area. It's still very difficult
Yeah,
to get. I mean, you can't really get it prescribed, but people have ways of finding it. And people who I have talked to, who patients who have tried it for either end of life or for like refractory depression, where like nothing helps. 1, 2 doses like is miraculous and it has long lasting effects. Now, of course, we always want to make sure that we're being careful and safe. So we're not asking you to go out and go do psilocybin, but there's data mounting. And I think in the next decade, we'll see that these medicines be used in end of life care, hopefully. It's something that I'm really,
yeah, yeah.
yeah,
And hopefully there's not going to be too much political blocking.
which there will be for sure.
I think this is important. Again, most of these hospice patients should be DNR. Okay, do not
DNR
resuscitate.
is, yeah, do not resuscitate.
Do not resuscitate. Meaning, no chest compressions, no, intubation. Uh, and again, sometimes it's easier in the home. One thing that I did was to talk to the family and say, look, when he stops breathing, you don't have to call 911. You can just call us, okay? And if they don't call 911, then, you know, they're not going to be resuscitated, okay? So that's one thing. That's not true in the nursing homes. In the nursing home, unless you have something written, they're going to probably call 911 when the patient. So it's more important, you know, in the hospital or in the nursing home setting to have, you know, and one of the things that helps these days is POLST, POLST, physician orders for end of life care, where the physician can actually sign, do, you know, no chest compressions, no feeding tube, everything. And of course, it's signed by the physician and the patient or agent of the patient. And these are orders that can go with the patient wherever they are, at home, nursing home, hospital, ambulance. So that's something uh, to keep in mind. But I think it's important to be individualize. The patient cannot make it. You know, they're not in a condition to make decisions like that, and they don't have advance directives. And um, the family just finds it difficult to say, if I sign a DNR or if I agree to it, I'm killing them. And I remember one case where the patient is in the nursing home and there were no advance directives. And I was dealing with the son, asking them, look, it's going downhill. What do we do? I don't think we should do chest compressions. We shouldn't do artificial breathing. Well, let me talk to the other family members. Let me think about it. Okay. And he kept just avoiding the subject. And then I happened to be in the nursing home when the patient was actively dying, and the son was there. I said, look, we have to make a decision. Oh, I don't know. And the nurses said, what do we do? And I said, let him go. Do not call 911. Do not do anything. I took that initiative because I saw how difficult it was for the son. The patient died. I went to see the son, and the son said, thank you, thank you. He wanted to make, he didn't want to make the decision. I had to make
And that's the
it.
art, right? That's the art of practicing this medicine is like
Right,
understanding what this person's grappling with and just knowing that they still want the best for their family member, but
right,
they can't
right.
make the decision, even though they know that it's best probably to let them go. So, like you lifted a huge weight off of his shoulders to have that insight and to be able to step in and do what you knew was right.
Yeah.
Yeah, thank you. That's such a beautiful example of that.
I think it's very important to look at difficult situations as challenging because if you say the patients are difficult, you are personalizing it. You are blaming versus just thinking of it as these are challenging situations and how do we deal with a challenge? It's a challenge. Let's meet the challenge. Okay. And listen, professionals are human beings, and sometimes we get frustrated, we get short tempered. And, you know, it's important to realize that. And sometimes those weekly meetings were good and just airing that, you know, God, I can't stand that wife. You know, it just, she's driving me crazy. Okay.
Absolutely. Yeah. And you know what? It's we're humans. Like we're not robots. Uh,
Right.
we have thoughts and feelings and emotions too. And um, it's really helpful to talk to colleagues who understand. And
Right,
like you said, it's never really about um, the patient. These are people that are under extremely difficult circumstances.
right.
And so just framing it as a challenging situation is so helpful.
Again, I can't emphasize how much the team is so important. And I don't think I could have done hospice without a team, you know. And that includes palliative care. The great thing about palliative care is that you introduce the concept of goals of care. What is important to you? You're still getting chemotherapy, but it's not working so well. What what do you foresee, after chemotherapy's finished? Or um, you're going, we're going to try to remove the cancer, but what if they can't remove it all? And so it brings a certain discussion that um, is very difficult for attendings to do, the oncologists. Your diabetes is getting worse. How about dialysis? What are the pros and cons of dialysis? Okay. Um, so these are, again, things that are can be best discussed not just with the physician, but maybe the chaplain, because somebody is religious, or um, you know, again, the social worker that can discuss more of what um, resources are available.
Yeah. Yeah, the team aspect, I wish was utilized in regular medical practice as well. I mean, I think
Yeah,
it would be just better patient care. It's just not the model that we've developed. So,
I think it's important that to realize that we have limits. Sometimes the pain is very difficult to control. Sometimes the problem is that you cannot convince the patient and the family to take it in appropriate doses, no matter how much discussion there is. Sometimes it's just a question of, and there are some people that say, I'm being punished and I'm accepting the punishment. The suffering is because I've been a bad person, okay? And I deserve to suffer. And, you know, if that person uh, feels strongly that way, you're not going to change their minds. You can try, you can have the chaplain again talk with them, but you have to realize that you can do the best you can.
and that's hard for us as physicians sometimes to recognize that we can't fix everything, right?
Yeah,
Even
yeah.
with best tools, there are situations that are just really hard and challenging.
It's very important to be appropriately humble. I think sometimes we get a little ego inflated because we have degrees and we have experience. But um, the fact is, particularly with hospice, we cannot beat death. And that's not the reason that we're doing this. And we can be wrong. We can sometimes choose wrong medications, or maybe the dosage is wrong and you get side effects. And again, there's conflict with the families and we can't really resolve it. I think it's important to realize our limitations. And I think it's particularly important when you're doing hospice and palliative care that there is still in the larger medical community a feeling that we're not really doing medicine,
Yeah,
right?
like soft. art of practice of medicine. It's not, there's not a lot of technology involved.
Right.
Just a lot of words and the soft skills. And
Yeah,
and even now where I practice integrative medicine, I feel like that's another area that's sort of not regarded as real medicine.
you're
But
right.
I can tell you hospice is powerful medicine. It can comfort people in ways that sometimes no pharmaceutical can. So,
Yeah. And I think palliative care has,
and yep.
again, helped acceptance. It's important to keep learning because things evolve and we learn new things and new medicines, new ways of doing things. And it's important to give it away. And that's why I was so, I was grateful that you found me and that I could work with you and find an eager student. And um, and I was working with residents throughout my Kaiser career, and we started a Kaiser Fellowship, which is a one-year training program for people who finished a residency,
Mhm.
whether it's internal medicine or family practice, but it can be EGYN, it can be surgery. In fact, one of the fellows, it's a one-year fellowship. One of the fellows is an orthopedist.
Mhm.
It's so wonderful because it now prepares physicians to do hospice and palliative care with true training, with good training.
Yeah,
They don't have to learn the way I did by trial and error.
yeah, absolutely. Absolutely.
and uh, and I'm so glad that I'm mentoring actually the Kaiser Permanent Fellowship.
Mm.
So I get together with the fellows and we talk and discuss things. Um, so it's important, uh, I think, for us as professionals to um, to teach, you know,
Absolutely. And you're,
and give it away.
yeah, and just raise the next generation of practitioners who are going to do this even better than us.
Right. Um, but you have to take care of yourself, and you have to take time off. And one great thing about Kaiser is we had generous vacation time. A lot of people didn't take it. They
Mhm.
didn't take vacations.
Right.
Um, and um, and again, being good to and making sure that other team members were involved and not feeling neglected. And but again, you have to have a life, particularly doing hospice.
Right.
And, you have to
Just disengage from
let
the
it
little,
be this
yes,
thing. Right,
yes.
right. Um, and uh, I felt very important that it. I felt so good to be doing it. Uh, it felt good. Uh, I was glad that it was my occupation, that I was compensated for it, but it felt more than that. And um, and if it becomes a job, you're probably it's probably an indication that um, something something needs to be fixed a little bit,
And
you know.
certainly there are easier ways to make money. And
Yes,
clock in, clock out, and disengage. But this is
right,
really something that it feels much more than a job.
right. Ira Byack is a pioneer in the field of hospice, and he came up with the four things that matter most at the end. And he said that it's important to say to your loved one, to your next, whoever it was, wife, husband, could be a son or a daughter, could be, again, significant others. Please forgive me
Mhm.
because we've been together and I'm sure I've done thoughtless things. I forgive you because it's natural in a relationship to do things that are hurtful, not intentional. Thank you. Thank you for all you've done for me. I love you. And these four are so simple and yet they really resonate that when you really think about it, these are the things that at the end are important.
This is such a beautiful lesson, and I hope everybody listening takes this in and thinks about how they can utilize this. I think it's simple. It doesn't have to be hard.
I I felt wonderful about my career. I enjoyed doing internal medicine, but I was getting restless. Then I started doing hospice, and I truly enjoyed it. But also, I really enjoyed the challenge of developing palliative care and making it available. I also, for a while, ran the chronic pain program, and that was truly humbling because benign chronic pain is a lot more difficult to
Yeah.
deal with than uh, terminal pain. I was involved in developing that fellowship, not only at Kaiser, but at UCLA, the palliative fellowship. I was involved again in developing the inpatient hospice program at UCLA. I loved those challenges. It wasn't just doing things, but it was to administratively overcome the blocks and getting
Yeah.
the people. But I noticed um, I was 74 at the time. I said, I'm not having as much fun. It is time. It is time to retire.
Well, I
And
I
yeah,
just appreciate so much that you still teach, you still give that knowledge away and help us become better doctors.
and I still enjoy that. But I felt that it was the right time to stop practicing. You know, here we are. I truly, truly appreciate the opportunity to be able to um, talk talk about my career and what I learned and and then give it away.
Absolutely. And this is just, it's just been an honor knowing you and to learn from you. You've made me a better human, a better person, a better doctor. You may not realize that just simple things you said during our time together have stuck in my head, and they pop up all the time when I'm working with a difficult situation. So thank you for your time, for your service, for just being such a great model of how we can bring comfort and care to people that might be suffering, and just showing us that, end of life can be something beautiful and not to be feared with the right support in place.
Thank you so much for this opportunity. And I appreciate that. Frankly, I truly appreciate the friendship as well.
I love getting any chance to see you. I'm going to see you this week. It's rare that we get
Yes,
together, so I'm going to meet you and with your wife, and we're going to have breakfast together this week when I come down to Los Angeles. So I'm just so
great.
forward to it. Thank you for everything. And I'm just forever grateful for everything you've done for me.
Thank you.